Hello and welcome. My name is Erica Seamers. I'm the Executive Director of the UCHealth Northern Colorado Foundation, and I want to extend my thanks to all of our donors and community members for joining us for this very special event. We're celebrating Heart Month, and we're also very delighted that our presenting sponsor, Dellenbach Motors, is making this wonderful event possible. We are coming to you from the UCHealth Heart Center of the Rockies on Harmony campus in Fort Collins. And we are here in a socially distanced manner, doing things in the virtual world that we're all becoming very much accustomed to. So again, thank you all for joining us. A little background on the foundation. Our UCHealth Northern Colorado Foundation supports Poudre Valley Hospital, Medical Center of the Rockies, Greeley Hospital, as well as affiliated clinics and programs through donations made by generous community members. Our donor contributions help in many ways to fill in gaps not covered by insurance, to accelerate advances in medicine, and to ensure the very best healthcare for our region. Community support like yours makes a difference to help us care comprehensively in so many ways. A few very current examples. Our mobile blood buses, which were provided through donor generosity, have been instrumental in gathering vital blood platelets and blood products all throughout the pandemic, especially important right now. Donor contributions to medical research through the foundation are also being used in the fight against COVID-19 in one way to help COVID-19 patients and their physicians understand blood clotting disorders and also to guide patient care. And in addition, donor contributions are helping to support collaborative research with Colorado State University to examine the long-term effects of the virus. So just a couple of current examples of how donor support is really making a difference for our community. During today's presentation, we welcome any questions that you have and encourage you to use the chat function. In Microsoft Teams, you'll see a chat box on the right of your screen. So please do enter any questions that you have in that area, and we'll be sure to answer them at the end of today's presentation. With that, it is now my pleasure to introduce today's speaker, Dr. Bradley Oldemeyer. He is the Physician Director of UCHealth Cardiovascular Services here in Northern Colorado, as well as the Director of the Structural Heart Program at UCHealth Medical Center of the Rockies in Loveland. Dr. Oldemeyer joined UCHealth in 2004 and is board certified in echocardiography, interventional cardiology, and cardiovascular disease. He's involved in dozens of research studies and clinical trials and has numerous publications to his credit. So with that, it's my pleasure to turn things over to Dr. Oldemeyer today.
Thank you, Erica, and thanks to the Foundation for this opportunity to present. It certainly is different than historical as we're doing this virtually, and at least partially for that reason, I thought we would spend time today not just talking about current cardiovascular trends, but the impact that COVID has had on our cardiovascular community in general. I'm starting with this first slide that is an example of increased cardiovascular deaths during the COVID crisis as a result, probably most likely to lack of access to what we would consider traditional healthcare. And so you can see there's these 5 columns. One is for ischemic heart disease, that would be making reference to heart attacks. And along the bottom are the months January, February, March, April, May, and June. And you see 2019 is the blue trend. In 2020, during the peak of the COVID crisis, in April and May, you see this high spike in the number of deaths from heart attacks. These are specific not just to COVID positive patients, but to patients without COVID as well. And so you can see that the last year has been very challenging from a cardiovascular point of view to see it's changed the way that we practice. And while we continue always to be striving for what's new and what's innovative and make sure all our patients have access to high quality care, we come across lots of challenges. I'll show more of this slide later on, but I thought it was a good introduction to the different types of things we may look at today. For those of you who don't know much about our history, I'll cover it a little bit, but cardiology in Fort Collins specifically was started in the 1970s by Gary Luckison, and Dennis Larson joined him at that time. We've now grown that we have 37 cardiologists, and we're recruiting another 2. We have 8 cardiovascular and thoracic surgeons. We have 18 advanced nurse practitioners or physician assistants. Our team has about 400 additional members. We cover 19 sites, which you see in front of you, and we cover the hospitals that you see listed. So each of those communities that you see listed is a place where we put physicians on a regular basis to provide cardiology outreach. The newest one on here is in Casper, where we have electrophysiologists who do pacemakers and ablations, who drive to Casper once or twice a month to see patients there who are then referred back to MCR for procedures. So you can see it's a pretty extensive list of places we go. We have full-time cardiologists who live in Steamboat and who live in Scotts Bluff, and we support them with specialty clinics in those locations. This model of going to outreaches is not unique just to the cardiologists in UCHealth in the northern region, but you can see that we also in the southern region cover all the way down to Trinidad, east to Lamar and Burlington, and we even have physicians from the University of Colorado Anschutz who go up to Billings to do a congenital heart clinic. And so we really have a large reach throughout the state and the region. I like to remind myself of what Heart Center of the Rockies looked like in 1995. It had 6 cardiologists. All of them did similar procedures. They all saw a lot of general cardiology patients. They all put in pacemakers. They all put in stents for heart attack victims. And that's quite different from how we do things now, where here's a list of our 37 cardiologists and the different subspecialties they do. And so electrophysiology is the practice of electrical complications with the heart. That can be the heart goes too slow and patients require pacemakers. It can be they go too fast and they require ablations. And we have 7 electrophysiologists who last year did over 1,000 ablations on patients from the region. Our general cardiologists are the type of folks who you'd see if you made an appointment to meet with a cardiologist and see what your risk factors were, or to address what we would consider a general cardiology problem. And we have about 19 of them now, and they're listed in that middle box. But they don't just do general cardiology and they don't just do clinic. They've really become experts at management of congestive heart failure, management of imaging services. We did over 600 cardiac MRIs last year. And if you go back just 2 years, we've done 50. And that's because we recruited general cardiologists with expertise in imaging because we felt it was a deficiency we had in Northern Colorado. And finally, we have interventional cardiologists. That's one of the roles that I play. But we put in stents for heart attack victims. We open arteries that have been occluded long-term and are causing symptoms. We replace heart valves through catheters. And it's really become a somewhat biased opinion, but a specialty which has become quite sophisticated. I've got an asterisk by Mo Lescani. He is a general cardiologist, or excuse me, an interventional cardiologist here, but he also spends about 10% of his time doing research. And that is supported, at least in part, through the foundation and very much appreciated in that role. I thought I'd teach you a little bit about the difference between electrophysiology and interventional cardiology. Electrophysiologists deal with everything from ventricular tachycardia, which is a heart rhythm that can kill you and often requires an ablation or a defibrillator, to removing pacemaker leads if they're infected, to doing complex ablations. The most common thing you'll hear is patients with atrial fibrillation have an ablation to prevent recurrence of that heart rhythm. Interventional cardiologists play a different role. We tend to deal with the arteries and the veins versus the electrical system, and for patients who are sick with heart attacks. And so we place stents in coronary arteries. We place stents in the legs and the abdominal arteries, things that are in your stomach, your intestine, your kidneys. And we have 2 cardiologists who place carotid stents. Those, as you know, are the arteries that go to the brain and put you at risk for strokes. And we do about 100 carotid stents per year between those 2 docs, and work very closely with the vascular surgeons who often will do surgery to treat those blockages in the carotid arteries. We also do something called brachytherapy, which is putting isotope, or it's called a nuclear isotope, and it helps break up scar tissue in coronary arteries. If you've had recurrent problems with stents, we're the only center in about a 5-state region that performs that service. And finally, on the top left, we do structural heart procedures, which means we can replace heart valves through catheters. I'll talk more about those later on. We're supported by these very able and expertise cardiovascular, cardiothoracic surgeons. Dr. Guadagnoli is on the top left. He's been in the community for 30 or 35 years as a vascular surgeon. Dr. Cummings below him now runs the department. And the three surgeons at the bottom are Dr. Douthit, Dr. Pan, and Dr. Glatter. Dr. Pan joined our practice about a year ago and has been an outstanding addition. On the right is Ron Smith on the right side on the bottom. He's a thoracic surgeon, works a lot with cancer patients. And on the top right is Damon Kennedy. He's a surgeon who works in our team exclusively in Cheyenne Regional Medical Center. And so we provide the cardiovascular surgical services up in Cheyenne. And in the middle is Dr. Richard Denny. He's a vascular surgeon who's joined our practice just this week. And we have high hopes of expanding a vascular surgery program throughout Northern Colorado. We've probably had a deficiency there. And so that's our team. I've been proud to be a part of it for 16 years now, but it's been growing in the community, originally in Fort Collins, and then Fort Collins and Loveland, and then Fort Collins, Loveland, and Greeley, where we have hospitals in all those sites, and Longs Peak Hospital in Longmont. And so those are the UCHealth hospitals that we cover in addition to all those other sites that I showed in one of the introductory slides. I thought I'd give just a basic anatomy review for you, as I'll be talking about some of these structures as we go along. The red structures on the outside of this heart are the arteries, and you can see they're labeled, but you have the left and the right coronary arteries and branches of them. When there's a blockage in these arteries, that's what causes a heart attack. And that's where a lot of our time is spent opening up those vessels. And you can also see the valves are labeled there, sort of starting top left, the tricuspid and the pulmonary valve, and towards the middle on the right is the mitral and the aortic valve. The valves that we're now able to replace or repair through catheters are the aortic, the mitral, and the tricuspid valves specifically that we work on at Medical Center of the Rockies. A little bit further history with cardiology. The gentleman on the top right is Dr. Forsman. In 1929, he took a catheter and he placed it in his vein that was in his elbow, and he advanced it until it went up into his heart. And he walked down the stairs from his lab to the radiology department and took an x-ray, and then walked back up the stairs to his lab and removed the catheter. And so it's the first story of a physician performing a heart catheterization, and he did it on himself. And that concept, very interestingly, is what we do now every day in our cath lab, where we go through the radial artery in the arm and under x-ray advance different catheters up to the heart. And so he was sort of cutting edge and proof of concept back in 1929. In 1960, the first bypass surgery was performed, the first heart transplant in 1967. Angioplasty is the method of taking a catheter, advancing it into an artery, inflating a balloon, and getting rid of the blockage that was there. And that was first performed in 1977 in Germany by Dr. Grunzig. And I'll show you pictures on the next slide of the actual procedure he performed. The problem with angioplasty is those blockages tend to recur, sometimes in the very short term, within a day, but sometimes over weeks or months or years. So it's not a good long-term solution for obstruction by plaque buildup or cholesterol buildup in the coronary arteries. And in 1994, the first stent was utilized. Problems with stents is they tend to narrow off over time. And in 2003, a stent that had a drug coating on it was approved by the FDA. And we're now on our third or fourth generation of drug-coated stents that go in coronary arteries. And that is what folks get these days on a regular basis in our cath labs. Here's that picture I made reference to, and it's hard to make heads or tails of, but it's noteworthy just from a historical point of view that the patient had a blockage in the far left slide on September 14th of 1977 and underwent an angioplasty 2 days later. And a month later, that angioplasty proved to still be effective. And in fact, this patient lived another 25 years and outlived Dr. Grunzig, who died subsequently. Coronary artery disease is the #1 killer in the United States. Atherosclerosis is the term you'll hear us refer to. On the left is a normal coronary artery. There's 3 normal layers of tissue there. On the right, you see plaque or cholesterol buildup. The process of a heart attack is cholesterol buildup, and then it breaks open and causes an acute problem where you get a blood clot there. So when we see these patients emergently, our goal is to get the vessel open, and that's done through a heart catheterization and stent placement. Of course, the key is to prevent this cholesterol from building up. And so primary prevention of heart disease is where we spend the majority of our time. And in fact, Dr. Luckison started a Healthy Hearts program, which has been present in the region for many years, and it provides education and screening for any students in Northern Colorado. It's a focus on healthy eating habits, regular exercise. They have lipid screening, blood pressure screening, and it's supported in part through the Foundation's WISH program. Last year, I should say December 2019, we celebrated the 50,000th student being screened in the Healthy Hearts program. So this is part of what the Foundation makes possible for us, but also can't be overemphasized the importance of early prevention of coronary artery disease. Let me give you a case presentation of a patient with a heart attack, which is also known as a myocardial infarction. This patient is 49-year-old male. He smoked cigarettes, he had high blood pressure, cholesterol, diabetes, and he had a family history of his father having bypass surgery in his 50s. And so that in itself is worth pointing out that the 5 traditional risk factors for coronary artery disease are tobacco abuse, family history, hypertension, high cholesterol, and diabetes. And so this is where we spend our attention trying to modify these risk factors. He had been playing tennis, he developed chest discomfort. If you've ever been in the emergency room with pain, they ask you to rate it on a scale of 1 to 10, and his was a 10 out of 10. He broke into a sweat, he was short of breath, and it rated to his arm. So a couple other learning points is we look at the type of discomfort the patient has. It's often described as an ache or a pressure. Often people say it's not painful, but it's uncomfortable. That's not uncommon at all. Associated symptoms are breaking out in a sweat, shortness of breath. Sometimes people are nauseated, and often the pain will radiate, whether it be to your jaw, your arm, or your back. Occasionally we see somebody where the right arm is the area of radiation. So I emphasize that any severe symptoms in the chest area should be taken seriously. Bystanders saw him fall to the ground and he became non-responsive. 911 was called and CPR was initiated. Here's an animation of what we would refer to as ventricular fibrillation. On the left side, before that electric shock, is a heart rhythm where the ventricle, the main pumping chamber, is not beating in an organized manner, and therefore there's no blood flow to the brain and the rest of the body. And in this case, the gentleman had an external defibrillator placed by the paramedics. It shocked his heart and it brought him back to normal rhythm. So the abnormal heart rhythm that kills folks is not in itself the heart attack. The heart attack is the blockage of blood flow. And I've covered these risk factors. I'm going to tell you not to be a couch potato, and I'll breeze through them. By treating patients with external defibrillators and by having systems in place to get heart attack victims in the cardiac catheterization laboratory, we've proven that over the last 20 years, we've greatly reduced the risk of heart attacks, but also death by heart attacks. And so it's impressive. Every now and then you'll get updates on a national or even international level about how are we doing in taking care of patients. And you see that death from cancer rates have come down very nicely, and that's also true with heart attack victims. Here's a picture of the patient I was showing you. This is his heart catheterization. It's also called a coronary angiogram. Let's see if I can back up and do it again. Might not be able to repeat it. But there was a blockage in the artery there that was at the top. And here's a picture of a balloon or a stent going in that artery. And afterwards, that artery is wide open with good blood flow. So that is the process by which we take care of heart attack victims. And we do so as quickly as we can. The paramedics will make the diagnosis. You should always call 911. You shouldn't transport yourself to the emergency room. And when they make the diagnosis, if it's after hours, they'll call in our cardiac catheterization team while they're in your house and diagnose you with a heart attack. They activate us so that we meet you at the hospital when you get there. After we put a stent in, we take a picture and we make sure the heart's squeezing well. On this one, the top right side of the heart doesn't squeeze as well as the rest of the heart because that's where the heart attack was occurring. That helps direct us in the care to provide for the patients. So prevention of heart attacks is managing your risk factors. I can't overemphasize the importance of daily exercise. We want heart attack patients, as well as all patients with the potential for cardiovascular disease, to exercise 30 minutes daily, or at least 5 days a week, and that markedly reduces your risk of having or dying from a heart attack. Appropriate diet should be followed. In general, it's a diet that's low in cholesterol-containing foods and low-fat diet. I think there's really been a trend over the last 5 years that is to the certainly beneficial, which is plant-based diets. Eating less meat and more vegetables is very good for cardiovascular health. And we look at those other risk factors. We control your cholesterol, we use blood pressure medications, we control your diabetes, and of course, we emphasize the importance of not smoking. So you might take a minute to enter any questions you have about coronary artery disease in the chat feature. We'll answer them all at the end of the presentation. And in the meantime, I'm going to go on and I'm going to talk about structural heart disease. And we're going to talk about those valves I made reference to earlier. So on your computer, find a picture of the aortic valve. That's the first thing I'm going to make reference to. And then we'll talk about the mitral valve just a little bit. Here's a picture of the aortic valve. On the left is a normal aortic valve. It tends to have 3 leaflets. They open when the heart squeezes and they close when the heart relaxes. Some people are born with 2 leaflets. It's called a bicuspid aortic valve. It's a congenital abnormality and is a common cause of aortic stenosis. In this picture, the valve in the middle on the right have aortic stenosis, which means that calcium has built up. You lose the flexibility of the valve. It's unable to open and let the blood out of the heart and go to the body. The common symptoms associated with aortic stenosis would be chest discomfort with exertion, shortness of breath or congestive heart failure, or passing out. About 8 years ago, in the end of 2011, a device was approved to replace aortic valves through a catheter, and that's called a transcatheter aortic valve replacement, or TAVR. And you see in red this line of the frequency of TAVR from 2012 to 2017. Became a very common procedure. The green line you see is the number of open heart surgeries for aortic valve replacement. And you see from 2012 to 2017, the frequency of open heart surgery to replace the aortic valve has gone down. But overall, you can see that we're treating a whole lot more patients with aortic stenosis than we did previously. And that's because the technology allows us to take care of high-risk patients who aren't candidates for open heart surgery and to fix their aortic valve through a catheter. So here's a typical case presentation of someone with aortic stenosis. This is an 85-year-old male. He's had increasing shortness of breath and chest tightness with exertion. He often becomes lightheaded and feels like he might pass out. An echocardiogram or ultrasound of the heart revealed the aortic valve did not open adequately and he had severe aortic stenosis. If this is left untreated, the death rate is approximately 50% over 2 years once aortic stenosis becomes severe. And so aortic valve replacement is recommended in all patients in which we can do this. I mentioned that historically a lot of these were done with surgery. That's an incision through the chest above the sternum and spreading the ribs. On the right side, you see sutures pulling a new valve down in place after the old valve has been removed. This is a tremendously effective technique for replacing the aortic valve. Unfortunately, it requires open heart surgery and subsequent recovery from this. Recovery from open heart surgery is 6 to 12 weeks. And so you can see that patients would really be enamored by the concept of a transcatheter aortic valve replacement. In this animation, you see that a catheter, which is that blue object there, has been placed in the aorta. This goes through the femoral artery, the artery that goes through the groin. And we can take a wire and we can place it across the aortic valve, which you see here on the top left. That object that's opening and closing as the heart squeezes is the stenotic aortic valve. It's heavily calcified, it's thickened, it doesn't allow blood to flow. So by placing a wire across that aortic valve, we can then advance a new valve that'll be directly in place of the current diseased aortic valve. And here you see that catheter is being advanced over the aortic arch and across the valve. And you'll see that it's very advanced technology. We're in about our 3rd generation of improvements in this valve system. We can move it up and down, we can move it left and right. This is all done through an X-ray machine in the cath lab. And when we like the placement, we inflate a balloon and it leaves this new valve functioning. You'll notice that the old valve is not removed with this technique, it simply is moved to the side. And it's noteworthy that this has become the most common way for fixing aortic valves in the United States and across the world. Last week, we put in our 1,000th transcatheter aortic valve at Medical Center of the Rockies. Here's an X-ray of this actually taking place. That catheter you see there is sitting right above the valve and takes a picture of it. We can inflate a balloon across that valve to make room to deliver a new valve. And here's a valve going in. When we like the placement, we inflate the balloon and the new valve is left behind and is fully functioning. That process takes about 10 seconds and you're left behind with a valve in that place that opens and closes just as your original valve did. So that's called a transcatheter aortic valve replacement. It's worth noting that of those 1,000 valves that we've replaced, about 90 of them were done by trial protocol. And so the research that's supported through the foundation has helped us to treat almost 100 patients with a transcatheter aortic valve. The thing I like to look at is how can we have access to the best technology and to the biggest patient population to get the technology to. And that's what research trials allow us to do. Quick picture of the volume over the years. If you just look at the right, it's labeled December. This lets us track from January through December of every year, but you can see the increase in mostly transcatheter aortic valve replacements at MCR. The top two lines are the most recent years, 2019 and 2020, and you see we didn't have the usual increase in volume that we had in all of the preceding years. And that's because we had 8 weeks of not performing any elective valve replacements at MCR during COVID. I'm going to talk now, I'm going to move on from the aortic valve and talk about the mitral valve. The most common mitral valve problem is mitral regurgitation. And you see with this arrow here that the blood flow is going the wrong direction. Instead of going out through the aortic valve to the aorta into the rest of the body, it's going back into the atrium, into the lungs. Mitral regurgitation is common. There's also congenital causes of mitral regurgitation, or it can be a result of a problem with your left ventricle being too weak and getting large ventricular enlargement, or an enlarged heart can lead to mitral regurgitation. So a typical case presentation would be, as you have here, a 50-year-old female with a history of a murmur since she was in her childhood. She's had increasing shortness of breath when walking upstairs, swelling in the legs for the last 2 to 3 months, and might feel her heart race irregularly, fast and irregular, which would be consistent with atrial fibrillation. The picture on the right is leaking of the mitral valve. That yellow going towards the top of your screen is blood flow that should be going the opposite direction. So this blood flow is going back into the lungs and making her short of breath. In this case, it's from something called mitral valve prolapse, which is something she was born with. I'll take a minute here just to comment on the imaging. I mentioned our general cardiologists were in charge of taking pictures of the heart. And so these procedures can't be performed without experts in imaging. And this is an example of an ultrasound of the heart. I'll show you a 3-dimensional picture, which they can obtain as well. But as we do these procedures, which is called a MitraClip procedure, we require outstanding imaging. So transcatheter treatment of mitral regurgitation is done with a device that currently is called the MitraClip. It's reserved mostly for high-risk patients. If you're a young patient, as this patient is, she likely could have proceeded with open heart surgery. Our goal is to improve the severity of mitral regurgitation, take it from being severe mitral regurgitation to mild mitral regurgitation, and that will help us decrease repeat hospitalizations for congestive heart failure and improve one's quality of life. The picture you have on the right shows 2 leaflets. The top right picture has a leaflet on the top and a leaflet on the bottom, and when those two don't come together well, then you can get leaking. On the middle right is a picture of a clip being placed and taking those 2 leaflets and clipping them together. It therefore prevents one of the leaflets that's misbehaving or prolapsing back into the atria to behave itself. And in the end, you'll be able to get rid of that mitral regurgitation. Here's a picture of the clip being placed. On the left side is one leaflet, on the right side is the other, and that clip is the bright thing sitting right there in the middle. It looks like an upside down T. And this is after we've grabbed those two pieces of tissue, those two leaflets, and clipped them together and gotten rid of almost all of the mitral regurgitation. Another view of the same thing. And here's a three-dimensional image of that clip sitting right between the anterior and the posterior leaflet. One leaflet's on top, one's on bottom, and they've been clipped together. So this is called transcatheter mitral valve repair, and it gives us the opportunity to get rid of somebody's leaky mitral valve through a catheter and preventing open heart surgery. The next step in mitral valve intervention is going to be mitral valve replacement, and that's when we'll enter the heart through a catheter, and instead of simply clipping the leaflets together, we're going to put a brand new valve in that position. And at Medical Center of the Rockies, we're starting next month with a brand new valve in research protocol. These devices are only available through research protocols, and our hope would be to treat 10 or 20 patients a year in a new trial that begins next month. So we're very excited about that. I'm going to move on from mitral valve disease, and I'm going to talk about a very common topic which lots of people have interest in, and it's atrial fibrillation and blood thinners. And so for many of you who are aware of atrial fibrillation, it's a disease process in which you can get blood clots in the left atrial appendage. And the left picture shows the blood clots in that appendage, which is on the bottom right side of the picture. And what happens with atrial fibrillation is these clots form and they can leave the heart, go up to the brain, and cause a stroke. And so our biggest concern when we treat patients with atrial fibrillation is the risk of stroke, and we recommend that they go on blood thinners. Historically, the option was Coumadin or warfarin, and I hear every day from patients, I don't want to be on that rat poison, because warfarin happens to also be what's put in rat poison to kill rats. They bleed to death. And of course, when we give it to humans, we monitor the levels very closely. But the risk of the medication is that you bleed too easily. We now often use things which you've seen on TV called Eliquis or Xarelto or Pradaxa. These are blood thinners that don't require Coumadin to be utilized. They're easier to take. They have fewer drug interactions. They have fewer interactions with food. And so we like them very much, but it would be nice to have an alternative where we didn't have to be on medication and could still prevent the risk of stroke with atrial fibrillation. And so on the right side screen, you see a picture of an echocardiogram. That arrow is pointing to an appendage on the left atrium, but specifically that white thing there is a clot of blood. And certainly that patient would be high risk for that clot to go somewhere, specifically the brain, and cause a stroke. And so the concept here is that if we could plug that hole, plug that atrial appendage, you could come off your blood thinners and you wouldn't be required to have that increased risk of bleeding. Here's an echocardiogram of an appendage that does not have a blood clot in it. And here's a picture of a catheter being placed in that appendage. We inject dye, and so we know the size of it. And here's sort of a long video where we're going to advance out of that catheter a plug, and that plug will stay right in that atrial appendage and prevent any blood clots from forming in that area. The dark black thing on your screen there is the TEE probe. That's our echocardiographic probe, and there's also a pacemaker in there. And here's what this looks like after the plug is in place. I'll just tell you that at about 5 o'clock on this, there's a plug where the atrial appendage would be, and it prevents any blood clots from forming in that region. So a very common procedure we're offering to several hundred patients a year is a Watchman device. It's a plug that plugs the left atrial appendage. It allows patients who are high risk for bleeding to come off of their Coumadin or their other blood thinners. The specific criteria required for patients is that you have to be a high risk for bleeding and a high risk for a stroke. And so not every patient with atrial fibrillation is a candidate for the Watchman device. What we've done with the 3 previous procedures you've seen here, the Watchman device, the MitraClip, and the TAVR, is we formed what we call a valve clinic or a structural heart clinic. And it's run by nurses. We have involvement by nurse practitioners, and we have physicians who are from all different specialties: surgeons, electrophysiologists, interventional cardiologists, and imagers, those general cardiologists, who all participate in screening patients and deciding if they're a candidate for these procedures. So this is a good opportunity to send us some chat questions about structural heart disease, which is the treatment of valvular abnormalities and different structures of the heart. I think we're doing well on time. I was going to take about 15 minutes, maybe 20 minutes, and talk a little bit about how COVID has affected the sort of day-to-day lives of physicians in Northern Colorado and, of course, the patients that we treat. You might all remember that January 18th, there was a news announcement that there was a virus in Asia that had potential to kill increased number of patients who contacted that virus. And it was in the United States, no doubt in January, but well recognized in February. And here's a picture that is simply a graph that says the number of cases per day that were diagnosed in the United States. On the far left is prior to March 27th when there were no cases. And at the time, this looked like a huge spike in the number of patients we were seeing across the country. And as a result, what we did is we eliminated all elective cases. So patients who didn't need to be in the hospital, we wanted to keep them out of the hospital. And in our clinic, we canceled clinic patients, all with the concept that we wouldn't be bringing sick patients together who would be exposing other people. And that could be that the physicians have the virus and spread it to patients, or it could be patients bring it to the hospital or to the clinics. And so our heart clinics canceled almost 10,000 clinic appointments in the months of March, April, and May. We returned to fairly normal activity at the end of May, and the first 2 weeks of June ramped up to what we would consider completely normal. We did do our very best to utilize virtual visits. The fact that you're on your computer watching this right now means you know what a virtual visit is and how it works. But we saw about 3,600 patients in virtual clinics in those 3 months. And so just a large concern that around the country, patients could no longer get what we would call the usual or the standard care. Keep in mind what this graph looks like, and that this is covering the months of March through June, because I'm going to show you a similar graph that includes the entire year. So that's spring of 2020. This is a map of the world that shows a reduction in cardiovascular diagnostic testing procedures. So people who had stress tests, people who had echocardiograms, people who had heart catheterizations. And if you look at the different countries around the world, the lighter colored ones, those in yellow and green, had a reduction of sort of 0, 10, 20, 30% in procedures. The darker colored ones that are the light blue all the way to the dark blue or black were up to 100% cancellation in procedures. And you see in the United States specifically, we canceled about 70% of our elective tests that were being performed. And I'll go back to this picture I showed in the opening slide. It's during that same period of time that you see a significant increase in deaths from cardiovascular disease. So that included whether you had heart attacks or whether you had high blood pressure deaths or whether you had congestive heart failure. All of these were impacted. Interestingly, congestive heart failure not impacted, as you'll see in the strokes, the hypertension, and the heart attacks. And I don't think we know the reason behind that specifically. But congestive heart failure patients, unlike heart attack patients, don't need as acute of care as quickly. And I assume that the elective cases or procedures that they were having done, it was okay to delay those by 2 or 3 months. Whereas patients having chest pain or high blood pressure, it was not okay. It's noteworthy that this includes patients who both had and did not have COVID. So COVID did affect patients coming into the hospital and having heart attacks. We saw many patients who were COVID positive and had heart attacks. And we had to treat, of course, in a safer manner. But this also includes patients who did not have COVID and simply didn't have access to the usual health care. So remember that slide I showed in the graph. Look at the bottom right here. Only a third of that is what I showed in the previous graph. You see what actually happened in volume across the country in COVID diagnoses really occurred in October, November, December, and January, where we had a huge spike in phenomenally high numbers of patients who had COVID. And so we sort of learned how to deal with COVID in the spring. And despite this huge surge we saw in the fall and winter, we found that we were able to run clinics in a safe manner. For those of you who've been to a clinic, you recognize you don't sit in the waiting room with other people, that you're screened for symptoms of COVID. Many places your temperature is taken to make sure you're safe to be in the clinic. And we continue to see the same number of patients in clinic as we had historically. We also let elective cases resume in the hospital. We found out in the hospital how you can take care of patients safely. And in fact, I would argue, and I think this is an important point, that one of the safest places you can be is in one of our clinics or our hospitals. Everybody's wearing PPEs. The sterilization is used in a much more organized manner maybe than before. Every room is cleaned after every patient. These sorts of things have occurred. And so the care that evolved into a patient-centric model, and we don't want patients to be in the hospital if you don't need to be, but if you need to be there, we want you there, and we make a pledge to you to take care of you in a safe manner. It's very interesting if you look at the number of healthcare providers at MCR that got infected with COVID, despite taking care of COVID positive patients every day, is very low. If we wear our masks, if we wear our gowns, if we sanitize appropriately, you can prevent the spread of COVID. The concern, and in fact, the employees we had who picked up COVID picked it up in the community almost universally. And so, they brought their kid home from daycare, and the daycare had an outbreak. Or people who went to parties or restaurants when maybe it was best to be staying at home would bring it back and have an infection. But very little transmission of COVID actually occurs within the walls of the hospital or the clinic. And sort of, a point of pride for me is that as we learned how to roll with the punches, if you will, that we were able to continue to do procedures through the rest of the year. So our electrophysiology volume actually increased at 4%. And I put a slide specifically at Poudre Valley Hospital, it increased by 1,900%. And the reason for that is we built a new EP lab. We were excited to bring that service to Fort Collins. And after COVID hit, we said, we don't need to back off. We're going to continue with our strategic plan, and we're going to take care of patients at PVH in our new lab. So a lab that previously had done 20 or 30 electrophysiology procedures a year is now doing hundreds. Peripheral volume, which is putting stents in people's legs so they have better blood flow to their legs, or stenting carotid arteries to prevent strokes, increased by 3% last year. The structural procedures I showed pictures of was pretty flat. It was up by 1%. And I made mention of the fact that cardiac MRIs, it was one of our areas of innovation. It was a region for growth, and we went from about 250 to almost 600 MRIs last year. So after an initial lull in the spring, we were able to resume normal activity. Another slide, which is an example of complications from COVID, if you will. This was presented at the Society of Thoracic Surgeons annual meeting on January 31st. And it's titled The COVID Effect. COVID effect leads to fewer heart surgery and more patient deaths. And so according to this study result, there were 53% decrease nationwide in all cardiac surgery volume. So I mentioned that as cardiologists, we were able to do things through catheters, but cardiac surgery was much more difficult to do. Our ICUs were full of COVID patients. We didn't do any elective cardiac surgery if we could avoid it because we simply didn't have the beds, the nurses, and the resources that were necessary. And so that led to 65% fewer elective cardiac procedures, surgical procedures, and 40% urgent cardiovascular procedures. So urgent or emergent cardiac surgeries, you never want to delay, but this is across the country trends that we're seeing as we tended to either patients didn't come in as frequently, they were avoiding the hospital because of COVID, or when they got here, it was more difficult to treat patients. The largest effect of this you would see as expected was in the areas with the most COVID. So New York City and New York State in general during that time period had the highest decrease in volumes of surgical procedures. And in fact, we have physicians here who were in New York and practicing at the time. Their cath labs to take care of heart attacks got shut down and were being used for ICU beds. And so just depending on how heavily the community was hit, you saw phenomenal changes in practice. Locally, we didn't have 53% decrease, but we did have about a 17% decrease. And so when elective surgeries went away, we had to treat patients differently. The other thing this pointed out is that of patients who had surgery, there was a higher death rate. So the death rate increased by about 167%. So the patients that we were taking care of are sicker patients. And so I leave this as an example that COVID has strained the healthcare system really at all levels. But I think as you do that we're sort of getting ahead of this, and we're able to see the numbers come down. We see vaccinations are becoming available. And so I think we all see the light at the end of the tunnel. But it certainly is going to be a different world when we come out of that tunnel. So rule number one is vaccinate, vaccinate, vaccinate. The way that we can decrease a recurrence of COVID surges is to vaccinate the most people the most quickly. And at the same time, I want to comment that we really have to wear a mask at all times. You should still socially distance. All those things that you've been hearing, as physicians, we absolutely believe. I have a very good friend who got COVID back in March, and I was talking to him in July, and he said, Brad, do you really think that masks work? And I was taken aback by him, but my answer was, I know of no physicians who don't believe 100% that masks work to help spread the COVID, to help prevent the spread of COVID. And so it's not just something that needs to be done in the hospital. If you're out in the community, you have your mask on, and be very cautious about the decisions you make. In general, if my wife and I think about doing something fun, we say, no, we probably better not. And unfortunately, that's the rule that's going to be around for a while. In clinic, you're going to see virtual visits continue. You won't see waiting rooms, and if you do, you won't see people sitting in them. And of course, you're going to have to wear your masks when you're there. Something I hadn't touched on previously, but is important, is we made a change where many procedures that used to be inpatient procedures where the patient spent a night or two, we looked at why we were keeping patients in the hospital, and we decided that if we could get them home the same day, we would. So even though somebody had an aortic valve replaced through a catheter that usually would be 1 or 2 days stay in the hospital, we sent those patients home the same day. And so many patients who had AFib ablations typically would stay in the hospital, went home the same day. Patients who had that left atrial appendage closure with the Watchman device, get the patients out of the hospital. And what we do is every day at 10 a.m. we have a phone call with the operating room, with the catheterization lab, with the anesthesiologist. We look at our schedule for the next day and say, do we have nurses? Do we have rooms to put the patients in? And can we proceed with the procedures? And very frequently the answer still is no, we don't have the room, we don't have the nurses, we don't have the OR staff, we don't have the recovery nurses, and we have to cancel procedures every day. And of course, we choose the most elective procedures. Often these have been things like orthopedic procedures, plastic surgeries, those sorts of things, still to this day don't occur on a reliable basis. I will say that, I haven't given any credit to nurses, but I say we need to roll with the punches. Every day is a new day. But our nurses who were clinic nurses found themselves working in the ICU. The recovery room nurses found themselves working in the ICU. All the surgical nurses were giving vaccinations. And so the nurses and the healthcare staff in general have stepped outside of their level of comfort, outside their boundaries, and they've really done a phenomenal job supporting patients at all levels. And so maybe, we're getting lemonade out of these lemons. We're learning lots of new techniques, lots of things that I think will stick with us long term. I want to comment just real briefly on our strategic plan. We want to have more patients seen virtually who otherwise we couldn't see in rural areas. We might have people call for second opinions and do virtual visits that might live in Billings, might live in Omaha, might recognize our expertise and reach out in that manner. We want to expand through research. I've given several very good examples. The foundation supports us in having time to do research. And Dr. Lascani is so brave that he can do research even without a librarian's help. He likes to live dangerously. And this year in cardiology, at our center, we've published about 10 articles in national journals. And so being involved in these research opportunities brings a lot of recognition to University of Colorado Hospital and Northern Colorado Cardiology. I'll comment that we have a goal to have a expansion of cardiovascular services at PVH. Medical Center of the Rockies has been phenomenal care for people in Northern Colorado. And one of the things I noted is that patients from Fort Collins now go to Loveland to get their cardiovascular care. And that's not our goal. I'm going to show you a picture here of a potential new clinic facilities at Poudre Valley Hospital, where we'll have cardiologists stationed there on a daily basis, providing electrophysiology, interventional cardiology, and full clinic services. I mentioned telemedicine. I laugh and say to boldly go where no cardiologist has ever gone before, because we actually don't want to go there. So look at this map. It's the original map I showed you, but all of these Dots with white in the middle are areas like Lander and Riverton, Wyoming, and Wheatland, Wyoming, and Torrington. These are in eastern Colorado and further into western Nebraska. These are all places that don't have cardiologists providing services that are more than 3 hours away by car. And by working with the local hospitals, we're able to see those patients virtually, provide similar services, and only bring them down to MCR or PVH if they have needs for invasive procedures. I mentioned research and publications. Here's a list of some of our publications. Here's the Poudre Valley Growth Plan. And finally, I'll just say our recovery strategies are different than dealing with COVID day in and day out. We need to continue to screen patients every day from the surgical and the cath lab point of view and make sure we get elective patients taken care of. We need to continue to ensure clinics are a safe place to be, and the public needs to be educated that you cannot be ignoring symptoms of cardiovascular disease, as well as strokes. It's safe to go to the hospital, and if you have symptoms, reach out to your physicians, go to the emergency rooms. This is something that can't be avoided. We have to, we can't permit increased number of deaths from things we know how to treat. So with that, thank you for your time. I think Erica's putting together a list of questions for us, and be happy to take anything. The easiest way is simply to do it through the chat. So get in that chat room and type any questions you might have for me about anything I've covered or any other cardiology questions that might have come up.
Wonderful. Dr. Oldemeyer, thank you so much for your presentation. What strikes me is the expertise and the world-class care that you provide routinely and are constantly upgrading for our community. And you've managed to sustain all of that while, as you say, rolling with the punches and adapting during the last unprecedented year that we've had. So kudos to you and your team for taking care of our community in this very dynamic environment. We have a couple of questions, and I'll start with one related to diet. I think people's ears perked up when you talked about plant-based diet and the qualities of a diet that are important for cardiovascular health. So the question is, what is your opinion of some of the recently popular diets that are higher in fat? For example, the Atkins or keto diet, if patients can successfully lose weight by eating more fat and fewer carbs? Sure.
So that's a common question. I was in clinic this morning. I got that question from 2 or 3 patients, which, somebody said I'd had a lot of success in the 90s, early 2000s with an Atkins diet, but realized that it's not really referred to as a cardiovascular healthy diet. So there's 2 issues that are involved. One is the food that you're consuming increasing your risk for cardiovascular disease? And we know that things that do that are things that are high in fat, and that are high in cholesterol. And so we continue to recommend not consuming high fat, high cholesterol foods. I think why the Atkins diet works is because it eliminates carbohydrates. And so your protein consumption goes up, your carbohydrate consumption goes down. And we know that carbohydrates are converted to sugars and converted to fats and are not healthy for you. And so if you look at evidence, scientific trials, you'll find that the Atkins diet is successful for people to lose weight, and it's successful, actually, interestingly, at lowering the cholesterol, similar to other diets. But it's still not the one that we recommend as a primary method. And what I tell patients routinely is, I want you to choose a diet that you can do the rest of your life. I don't want you to lose 20 pounds in the next 2 months. I want you to lose 1 or 2 pounds every month for the next year or 2. And so you end up at the same point. You can lose 25, 30, or 40 pounds, but you do it in something that you can do throughout your life. The diets I think people want to pursue are the Mediterranean diet, which has really good evidence that it's heart healthy. And so it's high in olive oil, it's high in vegetables. It does have meats in it, but it doesn't have processed meats. And so it's relatively high in fish. And so I'm not someone who's against folks eating meat, even though I think a vegetable or plant-based diet is recommended. But you want to choose appropriate meats, and it's what you've heard many times. It's fish, it's lean meats. That means poultry, chicken breast, these sorts of things. But really, I want people to fill their plate up with vegetables and then add a small protein on the side. And I think that's the healthiest, realistic diet people can do long term. There's no doubt that a plant-based diet, which means you're not consuming any animal products, is very healthy from a cardiovascular point of view. I think it's hard to keep up long term. It's a pretty major change for folks. But I tell patients, why don't you start with 1 or 2 days a week you don't have any meat with your dinner meal, and have it be simply a vegetarian meal. And then not all vegetarian foods are good for you. Fettuccine Alfredo is not good for you. And so, choose lots of vegetables, find something you like, and have it routinely as a meal, and go from once a week to 2 or 3 or 4 times a week.
That's wonderful. Thanks for the comprehensive answer. Another question related to lifestyle is, can you describe the role of stress on heart disease?
Yeah, I guess to answer the question honestly, no, I can't well. We know that people in stressful environments have increased risk of heart disease, and one of the reasons might be the effect on things like blood pressure. But another one might be that stress can induce heart attacks at the time. And so I made reference to those cholesterol plaque, or that atherosclerosis building up in those vessels. Those break open and cause a heart attack. And our goal is for those not to break open or pop open and cause blood to clot there. And so those are things like certainly cholesterol control with statins is an important one. Aspirin to make sure clot doesn't form there, but also reducing the stressors that you can in your life. And so about 15 or 20% of heart attacks are associated with emotional or physical stress. The rest tend to be pretty random. I think the harder question is, how do you deal with that stress? And that's hard to do.
So age-old situation, right?
You're right.
Question related to the post-procedure care. Do you send a person home after a procedure if there is no one at home?
No. So we have specific criteria we go through. One is they have to be close. And so we'll send somebody to a hotel. If they're from Scottsbluff, Nebraska, we keep them close so that if there's a complication, they can get to the emergency room. But everybody should stay locally, and everybody should have a support system there. And so we require somebody to be with them. And there's a few other criteria we go through. It's things that you would expect. Can you obtain your medication? Can you prepare your meals? Those sorts of things. So what we do is we take our healthiest patients, we do them as the first and second procedures of the day. Those patients can go home. The patients who might be elderly, more frail, or not have support system at home or from out of town, we do them later in the day and they spend the night.
Very good, thank you. I'll close with one more question, and I'll also share that if there are any questions we did not get to this afternoon, we will send a follow-up email to all of our participants with a recording of today's event, as well as some answers to any questions that we may not have been able to cover. So last question for you is, can you share the timeline for cardiac services at Poudre Valley Hospital?
Yeah, I'll share the timeline as I envision it, and sort of what those services are. This has been a goal that's, as you can imagine, taken a long time, and it'll be multiple phases, some of which have already started and been completed. And so the new emergency room, if you will be sort of phase 1 of updating of Poudre Valley Hospital. That came with it a tower and a floor for orthopedic surgery. Relocating the lab and the pharmacy. So all that was sort of phase 1. The space that's available at PVH becomes the old laboratory and the old emergency room. And so all of that, as well as a new face and entrance to the hospital, will occur. As you can imagine, that takes a lot of time. And so phase 2, which is the first floor, includes the entryway, cardiovascular services, GI services, is going to be initiated within the next several months, but it's planned to be an 18 to 24 month build out. And that also includes women's services at the same time, which is going to be on the 3rd floor. So a lot's going to be lots taking place at Poudre Valley Hospital over the next 2 years. And then we'll move on to phase 3, which cleans up some of the other floors. So our goal is to have Poudre Valley Hospital look and feel like a brand new hospital and have similar services. We don't envision that we'll be doing open heart surgery there. We still think it's absolutely best care to get the sickest patients to an area that specializes in that. And so open heart surgery, most of the procedures you saw me present today are at Medical Center Rockies and will continue to be. And they're transferred from PVH, from Greeley Hospital, from Longs Peak Hospital, all of our own facilities, as well as lots outside of our region. Long project. I'm looking at spring of 2023 to move in there. So.
Very good. We're definitely excited to see this Poudre Valley Hospital become fully upgraded and fully renewed to serve our community for the next century. I want to thank all of you in our audience for joining us today and for your questions and participation. I'd like to give a great thanks to our production team of Lindsay Hertz and Linda Hardy. And of course, thank you to our partners at Dellenbach Motors for your steadfast support for health in our community. Contributions from our community help to make our cardiac program among the best in the world. Dr. Oldemeyer mentioned support for research as well as for our Healthy Hearts program provided by individuals as well as contributions and grants from several prominent local foundations. If you would like to learn more about donating to support cardiac care through UCHealth Northern Colorado Foundation, we invite you to contact us, and you can find more information on how to give in the meeting chat. Again, we're so very grateful for you joining us today and wish you a wonderful afternoon. Thank you.